Live.
Good
Irbaaz.
morning. All right. Good morning, everyone. My name is Irbaaz. I am an integrated cardiac surgery resident at Yale and also associate editor of Journal of Cardiac Surgery. It's my pleasure to welcome everyone to another edition of Journal of Cardiac Surgery's live talk. We're joined again by several eminent cardiac surgeons, and I will introduce everyone before we get started. I will begin by Dr. Anyanwu, who is from New York, Mount Sinai. He is an expert in mitral surgery. He will be joining our discussion. We also have Dr. Francis Pagani, who is from University of Michigan, also an expert in heart failure transplantation. We have Dr. Yarborough, who is from University of Virginia. She is also here with us today in between her busy schedule. And we have Dr. Thomas Salerno, editor-in-chief of Journal of Cardiac Surgery. He is from Miami. He is also joining us this Sunday morning. We have Dr. Gianluca Torregrossa, who is also an expert in robotic heart surgery. He is joining us as one of the moderators of this and also one of the editors of the journal. And we have Dr. Paul Tang, who is one of the senior authors of the paper that we'll be discussing today. He is also from University of Michigan. Thank you again, everyone, for joining us. I will hand over to Dr. Paul Tang if he can please give us an overview of the manuscript that we'll be talking about today and how they went about this study.
Okay, thank you very much. First of all, I'd like to thank the Gianluca and Dr. Thomas Salerno and the editors team at Journal of Cardiac Surgery for the opportunity to present this paper. I think it's a interesting topic, somewhat controversial, so I'll be interested in hearing some of the discussions later. But the paper is about preoperative moderate mitral regurgitation following LVAD implantation. We're focusing on moderate. I think severe may be a little bit of a different beast, but no conflicts of interest. So our paper looks at an institutional LVAD population from 2003 to 2020 and identified 190 patients with pre-op moderate MR with a median clinical follow-up of about 3 years. Echo follow-up at about a month with a normal functioning LVAD. The vast majority, 84%, had downgraded to mild or less MR, while a minority, 16%, remained at moderate, mostly moderate, sometimes a little greater. Looking at the demographics, they're pretty standard end-stage heart failure patients with an mean age around the mid-50s. Many are male, 80%. For our population, about somewhere between 10-15% were on temporary circulatory support beforehand, so tandem heart, ECMO, and so on. When you look at the hemodynamics on cath prior to LVAD, looking back after you know what the result of their MR or LV unloading and downgrading of their MR severity, the people who had persistent moderate or greater MR after LVAD preoperatively had higher pulmonary capillary wedge pressures and higher pulmonary artery pressure. So there's already a signal there that their MR may not resolve all the way. Next. So, and pre-LVAD findings, the incidence of moderate severe TR is about the same, a little less than half. Interestingly, their left ventricular diameters tend to be larger in people who don't resolve their MR as well, by a few millimeters, at least pre-op. In terms of operations, the same number for both groups, about a third, because they have similar number of moderate severe TR, about a third underwent tricuspid valve repair, probably mainly the severe TR group, and some underwent aortic valve repair too. Post LVAD is it's interesting. At about a month, for the people who have moderate or greater residual MR. A good number of them had recurrent TR, about 46%. And so once they're unloaded, their LV dimensions still tend to be a lot larger. Actually, this difference is accentuated. It's about 1 centimeter larger in the moderate or greater MR group. So once you get them down to their native LV size, where they're no longer volume overloaded, this difference is accentuated. And that also goes for the left atrium. These people tend to have larger left atrium. Postoperative outcomes for this short follow-up, we didn't see any difference in RV failure, LVAD use, or 30-day operative mortality. And there was no difference in overall survival. So in conclusion, in our paper, the large majority of patients with pre-LVAD moderate MR have improved MR severity to mild or less. It is, for a group with significant residual MR, it is associated with preoperative greater LV dimensions, higher wedge pressures, and higher pulmonary vascular pressures. However, in this small population, it didn't really influence outcomes. And our conclusion is that for mitral valve intervention, whether you do mitral valve repair in people with pre-LVAD moderate MR, the large majority don't need it.
Okay. I'm trying to pass here. Thank you so much, Paul. It was a great presentation of the paper that you submitted to Journal of Cardiac Surgery. And we actually really love the paper. That's why we pick it for this conversation that wants to be a very friendly conversation on a Sunday morning with your cup of coffee and just chit-chat for around an hour about a topic. And I would love to start with Dr. Pagani. I'm not an heart failure surgeon. I was in love with heart failure, but then after working with Dr. Anyanwu at Mount Sinai, I saw the type of life that he was doing. I said, I can't. This is like, my mother didn't make me to work as hard as Dr. Ani does. But I've always been very fascinated about LVAD and heart transplant. So before we enter in the topic of moderate MR in LVAD, can you, Dr. Pagani, give me and give all of us a little bit background? Let's talk about severe mitral regurgitation of the time of LVAD. When did we start to think that was a good idea to consider a surgery for it? What are the type of data that we have from the trials? Is it worth it or not? Is it justifiable or not? And when is, in your personal opinion, and we're talking about severe mitral regurgitation, when it is, in your opinion, the type of patients where you want to address the mitral valve during an LVAD placement?
So I would start off by saying that traditionally, historically, the idea is that most mitral regurgitation resolves in the following LVAD implantation. And so the traditional sort of approach was that mitral surgery was unnecessary in this population. There has been a lot of accumulating evidence to suggest that for those patients that don't have resolution of the MR, the presence of severe MR in the post-LVAD implantation phase, after following LVAD implantation, is not necessarily benign. There's a number of studies that have consistently shown higher readmission rates and more right heart failure for those patients with residual MR following LVAD implantation. And then there's been some data now showing differences, such as Paul has shown here, anatomical differences in terms of ventricular size, the geometry of the mitral valve, preoperatively, that can predict those, or more likely those that have residual MR. So there's some thought, could we start repairing patients with what we think are characteristics most likely to have residual MR? I don't think the data is strong enough to make recommendations yet. There was recent data from the Momentum 3 trial that demonstrated, only a small percentage of patients have residual MR, particularly with the HeartMate 3, something approximately 6%. And of those patients that have residual MR, survival did not seem to be affected, although the numbers were really too small to make, a really solid assessment of that. So I think at this point we know that residual MR probably causes some degree of problems in terms of remodeling after the LVAD and pulmonary hypertension and RV dysfunction, but we probably don't know who to best address that preoperatively.
Perfect. So when do you, like, let's say tomorrow you have a patient with severe MR and LVAD, when do you decide I address the mitral on this one, and when you say no, this is like, it's better to avoid, to seek, or not worth it?
Well, truthfully, I think the only setting where that I would truly approach the mitral valve is someone who I thought might have a potential for recovery. So if there's a young patient, a non-patient, short history of heart failure, who has primary or secondary MR, then I would address that to facilitate recovery.
I see.
But I think in terms of otherwise, I probably would not address the mitral valve unless there was primary pathology there with severe MR.
Dr. Anyanwu, what do you think about this statement? Are you agree? This is your practice as well. What do you do in LVAD, severe mitral regurgitation patients that comes and needs an LVAD?
Personally, I repair all patients with severe mitral regurgitation. So we've been doing that for at least the last 9 years.
I see. And what is your taking home? Why you have been in this level of aggressiveness? I'm sure there is a justification, as always, of what you do. What is, in your opinion, the benefit for a patient to receive a mitral valve surgery and repair during an LVAD implantment?
I think the main benefit is better offloading of the right side of the heart. The pulmonary artery pressures and the pulmonary vascular resistance comes down. So if you have a patient with a high PVR going in for transplant, I think if you get rid of the mitral regurgitation, we have published data that suggests the pulmonary hemodynamics are better. And I think with that, the whole LVAD function is better. But if we switch back to this paper, though, I'd like to comment on 3 things which I think are critical flaws with this paper. I think the first is the definition, the use of moderate mitral regurgitation. There's practically no indication for intervention for moderate mitral regurgitation in surgery in general. If you look at degenerative MR, functional MR, rheumatic disease, the guidelines do not indicate intervention on moderate regurgitation. So I think when we start introducing moderate regurgitation into any mix, we're going to get mixed signals. And really all that's of interest for this discussion should have been severe mitral regurgitation. And I think one should have left it at that. I think the second flaw is the population itself. So if you look, the study started in 2003, which gives you about 10 patients a year. And I don't think 10 patients a year will give you sufficient granularity to address a question as nuanced as what's the fate of mitral regurgitation. And if you look, because the study started in 2003, the question you will ask is, how close are implants done in 2021 to 2003? And what can we actually learn from such historical patients? And indeed, most of the patients did not have the device in use today, which is the HeartMate 3. So in the entire study, only 20% of patients had the HeartMate 3. The bulk of them had the HeartMate 2 and the HVAD, neither of which are available today, as you know. So the question is how one can extrapolate data from historical patients to current patients. The hope would be that mitral regurgitation itself is independent of the device, so it doesn't matter when you get it, how you get it, but we all know the devices also have their own unique characteristics. And I think the last flaw, I think, is we in the LVAD community, or indeed in the surgical community, we always look at survival. And we say that because patients survive the same, something didn't matter. And I think we have to move beyond that. Because if you look at the survival in this paper, like other LVAD papers, it's not great. By 5 years, the mortality was almost 50% in both groups. So when you have a disease with such, or technology with such high mortality, you're not going to shift mortality by making small changes to the surgical technique. It would never happen. So you need something more substantial to impact mortality. If you're going to impact mortality, if you're starting at a 50% 5-year mortality, it's going to be by 2%, 3%, 4%, and you will never demonstrate that with 10 patients a year. You need a bigger cohort. So I think we have to look beyond mortality and start looking at quality of life indicators, the functional status of these patients on the LVADs. And I suspect that if you find patients who 3-4 years out have severe mitral regurgitation, I bet you their quality of life may be different from those who have mild mitral regurgitation.
Thank you so much, Dr. Anyanwu. Paul, you are the first author on this paper, so I think that it's now your time at least. Reply.
Yeah. And so my approach, I think, is I know Frank doesn't agree with this, but I would do mitral valve repair if there was significant RV dysfunction. I think, well, we previously published a paper which says that if you had significant RV dysfunction, and even more so if you have significant tricuspid regurgitation, that you're more apt to get RV failure with significant residual MR. And how to identify the people with who are not going to resolve their severe MRs. And I agree with Annie there. I think, although this paper is about moderate, I think the money is in the severe population, and recognizing that it's a spectrum from moderate to severe. So for people who have larger LVs, we've shown that they don't resolve. So depending on the reference patient size, so it's 7 centimeters or larger, 7.5. I'm more likely to repair the mitral valve. These people have very large left atria. It's not hard. You don't have to cross clamp. You just vent them through the LV and the apex once you have your ring in place, and we always place a roof vent so to prevent air embolism, and that's kind of my approach. And I agree with Annie also about the length of time. And currently with the technology we have, many of the LVAD patients only have their LVADs, before they go to transplant for about 3 years, 4 years. And we know that in terms of impact on RV dysfunction in people with, if you do a cabbage, for example, on people with low EF, down the line, their survival is really impacted by their right heart. So they can maintain their LV EF for a long time, but the right heart eventually fails. But that process takes many years, 5 or more years. So as the technology improves, and we have, there's talk about partial support technologies that can be inserted peripherally, I think this MR issue is going to become more relevant.
Thank you so much. Leora, tell me, what do you think, first of all, what is your practice? What do you do? LVAD patients, severe MR, what do you do generally? A second, after reading this paper with a moderate mitral, what is your position about that? Do you ever thought to approach moderate mitral regurgitation in your LVAD patient population, or where is your mindset in this sense?
Yeah, thanks, and thanks for inviting me to join the panel today. So I would say as a whole, for my moderate mitral regurgitation, it is not my practice to even entertain repairing or replacing the mitral valve. And in fact, even with severe, I think, previous data has been pretty clear on that while you may have some residual effects that you don't know exactly who that's going to be, or in my opinion, there's only now becoming an accumulation of data to really suggest that we need to do additional interventions in the population. And I think it's important also to understand a little bit about the type of VAD, where you are titrating your speeds to. Are you titrating to effect? Are you following that patient for recurrent MR and then adjusting your speeds thereafter? So I think that What you do in the operating room is important, but these patients are so dynamic afterwards in terms of their either recovery or non, that they need to be constantly evaluated. And in those patients who have residual MR, despite optimization of the LVAD medications and diuretics, I do think that there is a role for then considering perhaps a post-implant technique. And so for those patients who look like they're on the road to recovery, who've had residual MR, we've actually done several mitral clips in those patients with good success and good explantation. So I think it's important to individualize your approach, but as a whole, I don't generally treat the mitral valve at the time of LVAD implant.
I see. And your opinion, a very quick line on your moderate mitral. I mean, what are your thinking about moderate and LVAD? You said it. I mean, you don't treat severe, so it's clear that you don't treat moderate. But do you
Correct.
the conversation should stay here, or we should have still you need more data to support your position with to see a benefit for treating severe mitral? That's your line.
Yeah, I think that's a fair assessment of my opinion on that. But these conversations are very interesting. I'd be curious, in those who repair it routinely, techniques and are there patients in whom you clamp and plege versus treat through the apex? Like, what is your approach surgically?
Dr. Pagani, tell us your approach surgically. If you have to do a mitral during an LVAD, how do you do it? From the apex, exactly. How do you expose it? Where do you cross clamp and give cardioplegia? How you do it? I
would do it through a transeptal approach. So, and I would do it with cardioplegia. And that's because generally in the situation that I'm doing it is typically for primary pathology, that I'm doing it because I think I want to enhance recovery. So I'm not just generally doing it for geometric changes or secondary MR. So that could be done, without arrest and such and so forth. So, but I do, I want to get back to the question, routine mitral valve intervention for everyone with mitral regurgitation. I really, I find that a difficult approach. One, because we know, and the data is really consistent on this, is that the overwhelming majority of patients have resolution of their MR. So, at best, 10% may have residual MR. So to do a procedure in 9 out of 10 patients that may be unnecessary, I think warrants really strong consideration, in thinking about the approach. I don't argue with the concept that residual MR is bad. I do probably think residual MR has consequences. And I think if we had better ways of discriminating patients that would have residual MR or not, I think routine operation on the mitral valve for those patients we would know have residual MR. But to subject, 9 or 8 out of 10 patients to an operation or a procedure that they don't necessarily need, I think is not the correct approach.
I see. Very interesting point. Dr. Anyanwu, how do you do your mitral valve surgery during your LVAD implantment? Where is your cannulation strategy? Does it change? Where do you expose your mitral, and what type of mitral valve repair you generally perform on the patient?
Before I go to that, I'll just correct something. I think, Dr. Pagani, when you say 10%, that will be if you look at moderate patients. But there are quite a few series looking at patients with severe mitral regurgitation that show about a quarter of patients will continue to have persistent regurgitation. So I think we're trying to help about a quarter of patients, not 10%.
Well, I think, if you look at the Momentum 3 trial, which is all the patients, they looked at, the Momentum 3 trial data. The patients with moderate to severe MR in the postoperative period was only 6.4% or something. So even let's just say it's 10 or 12%.
The Momentum trial, though, is a very selected group of patients that are not generalizable. It excluded anybody with significant RV failure that might go to LVAD. And as Paul said, a lot of these patients that we're talking about, benefit of mitral regurgitation, are people with very bad right ventricles, and they wouldn't have got into MOMENTUM trial. So I don't think we can use the MOMENTUM trial to define natural history of anything after LVAD, because that's a very selected patient group. It's not typical of most patients you operate on.
But we know, though, that the results of the MOMENTUM 3 are very generalizable because one is about 50% of the LVAD population is represented by those in the, we published a paper, Alex Brescia published 2 papers on this, where they, looked at the generalizability of the HeartMate 3 findings. And then we recently published, real world experience in INTERMACS, and also with the real LVAD study through a Medicare population, and found that the survival, was similar. So, to actually similar or better to trial findings. So I think HeartMate 3 findings are generalizable. And I agree with you that we probably excluded some patients with severe TR, and severe RV dysfunction. But even if we double that percentage, we're talking about, 15% of patients might have severe residual MR.
Well, I think if you go to the INTERMACS and look at the incidence of LVAD use, it's about maybe almost 20 times that in the MOMENTUM trial. If you look at the incidence of dialysis, it's much higher. There's so many patients that we operate on every day that were excluded from the MOMENTUM, which is why a lot of centers that kept a registry, they randomized about a quarter of their patients. So I think we can't say it's generalizable. But Gianluca, I'll go back to your question so I don't detract you, because you're looking at me with an evil eye.
No.
Sorry, so to repair the mitral valve, I think Dr. Pagani mentioned something which is very important, which we should differentiate here. He mentioned it in passing, and he said he repairs for primary MR. So I think for sure, if you have like a flail leaflet, that I think most surgeons should fix. But most of my discussion, I think where Paul is going is about secondary MR, what we do for secondary. But primary, I think it's important we fix. So I do similar to what Dr. Pagani does in terms of we always go through the septum, because the exposure is much better. And I find with that, you don't need to clamp the heart in the vast majority of patients. So you just do it with the heart still, with the heart fibrillating. We usually put in a complete ring. There's no need to downsize the ring like you do for usual functional MR, because the ventricle will remodel once you put the LVAD. It will shrink down. So there's absolutely no need to downsize, and you don't want to induce functional stenosis. So that's a standard approach. No cardioplegia, but if you have to give cardioplegia for any reason, you do. Sometimes it's difficult to put stitches around the aortic valve area with the heart beating. If that's the case, just clamp the heart for like 2 minutes. You don't need cardioplegia. Clamp the heart for 2-3 minutes, put your sutures, take the clamp off. But that said, we've moved away from that, and the vast majority now, I'm doing a double orifice repair, edge-to-edge repair through the apex. After the co-opt data, I've been skeptical about edge-to-edge in general, but I've actually found that if they can achieve reduction of MR in a lot of patients without annuloplasty ring, then surely with an LVAD, if you shrink down the ventricle, you should get good effect with an edge-to-edge. And certainly we've been doing edge-to-edge for a few years as the primary mitral approach, especially because a lot of the LVADs are true mini approaches, and we find that it seems to be as effective. So edge-to-edge and then annuloplasty is the second technique.
Very interesting. I've never thought to hear edge-to-edge pronounced by Dr. Anyanwu a couple of years ago. But definitely these papers that are coming up are changing our view or are influencing correctly our daily practice. Paul, what is your practice? LVAD patients, severe MR, you want to do the mitral, you think is good for that individual patient. How do you do it?
Yeah, so as I said before, we always place I always put a root vent, and I would put a vent through the pulmonary vein and put it into the pulmonary vein, and then after I put the ring on the LV apex, I'd put a little drop-in sucker at the apex, so it's well vented. you can see everything very clearly. I do a transeptal approach, and I put in a annuloplasty ring. Somewhere anything bigger than 30 or bigger, generally a rigid or semi-rigid ring of your choice. And the nice thing is, in the LVAD setting, you're not so the key thing is not to cause mitral valve stenosis. And if you cause, I don't know, what's the incidence of SAM in people with LVADs? Not that it matters as much, but
do you ever have
not much to worry about?
Do you have ever had SAM after?
No. What I'm saying is, all you have to do is downsize the ring, and you don't have to worry about a lot of other stuff that you have to be concerned with in other mitral valve repair settings.
Sure. And have you ever had a stenosis on one of your patients?
I have not. No.
No.
I always I find that a ring that's 30 or larger is always sufficient.
I see.
For flow into the LVAD. Yeah.
Dr. Pagani, what do you think about mitral patients that now are coming for an LVAD evaluation who have had a mitral clip implanted? So now we are talking about patients with a mitral clip implanted to try to temporize or improve their heart failure symptoms, and now they come for screening. They walk into your office or are presented at your heart failure team meeting for LVAD evaluation. What do you do on that clip other than taking amazing pictures? What do you do with it? Do you leave it? Do you remove it? You take one of the two out, because they always implant two. There's never like a patient with one mitral clip. There's always one or two there. So what is your approach on this type of patients? You see them?
We've only had a few of those, and they haven't had two clips. They've only had one clip, and I've left them. But I'd be interested to hear Lior's experience with the clips post LVAD, and how effective was one clip, and what were the gradients that you had with that approach?
Yeah, so we've had two now who we've clipped, and the first one was a young woman who came in acutely with decompensated failure, both right and left ventricular dysfunction. We actually looked closely at her valves and elected only to treat her tricuspid valve, and then followed her thereafter. And what we did look at the mitral valve, though, was whether or not it would be potentially clippable in the future. So if it wasn't, then I was going to plan to treat it at the time of LVAD implant, because we thought at that time that she was actually going to probably go on to transplant or need to go on to transplant. Now, interestingly, she did recover with good medical therapy, and once after a prolonged course, actually, of RV failure, et cetera, once she was treated appropriately, then the only thing left was the mitral that was still residual on her. And we actually got a very nice repair. I don't have the data offhand, but with just one clip alone, turning down the LVAD at the time of the procedure to sort of maximize the visualization and coaptation points for the proceduralists. And she had a great result. And the plan was then to explant her the next day, which we did successfully. And that was almost a year ago now. So that was our first patient with that. And the second one is somebody who's also had substantial recovery in terms of LVEF, but he still has some degree of residual MR, which is why we treated him also with a clip. And he's not completely resolved in terms of his pulmonary symptoms, I would say. So I think in this instance, his clip has been helpful, but not a complete success. And so we've not yet explanted his device either. And I think it depends in terms of timing and procedural complications, et cetera. We're so far happy, but like I said, the N is still small.
So I have a follow-up
and that's
question.
Post. I think to your point about the pre, I've seen anywhere between 1 and 4 clips implanted, and the 4 clips we removed everything in that instance, and did need to replace that mitral. But the 1 clip, if there's no stenosis there, we'll just leave it in place, and I haven't seen any trouble with that.
Yeah. So just a quick question to follow up on that. How do you determine which patients to repair versus clip? And also, when you were placing the clip after the LVAD, did you reduce the flow? How was that performed?
So at the time of clip after LVAD, is that?
Yes, correct. He was asking when you implanted the clip after. So you have a patient with an LVAD. Now you are crossing the septum and ready to implant the clip. You reduce the LVAD at that time. You do it before the procedure. What are your worries of embolize the clip or losing the clip? Is the suctioning effect of the LVAD detrimental in your or making more complicated your clip deployment, or what was your?
Yeah, it's certainly part of the discussion because I think it's relatively new, and I always try to be present at the time of clip placement, and do turn down the speeds substantially. They're sort of, and the clip usually has pretty good capture. The only time I've heard about clip embolization was actually LVAD implant after a clip, and so I know that it seemed like it had just partial attachment in that instance. I haven't heard, and I don't know if the rest of you have, of an LVAD, a clip embolization with an LVAD already in place.
Dr. Anyanwu, what is your take? What do you do when patients with a clip and that comes for an LVAD?
I mean, I just haven't seen Leora's scenario because we always fix severe MR. We've never had the scenario of a patient recovering that has severe MR. So they would, if they have severe MR when they're recovering, it means they never had it at the beginning, which is unusual, as Dr. Pagani hinted. I think if you repair severe MR up front, you never have a scenario to have to put a clip afterwards. But if there's a clip already, we're quite happy about that. We put in the LVAD. Because usually most patients, because if you have a clip and it induces mitral stenosis, you become very sick. So most patients who have a clip then progress to transplant, it's not because of mitral stenosis, it's because of left ventricular dysfunction. So we just go ahead and put the LVAD and we leave the clip inside too, because as I said, we're doing edge to edge from the apex for some of these patients. But I think one problem, though, I might have, Leora, with the approach of putting a clip and then going the next day is, if the patient really has severe MR, it's very hard to assess the ventricle for recovery in a patient with an LVAD, because if you take away that MR, if you do that to 10 patients with severe MR, you think the obvious is to take away the MR and then take away the LVAD at the same time, one day after another. A lot of patients, the increase in afterload on the LV might be quite dramatic, and the LV may not be as good as you can. So, like, if I were using that approach, I'd probably go more along the line of the second patient, put in the clip, and then assess the patient formally over a period of months before committing to LVAD removal. But I don't have experience in that, so that's just theoretical.
Yeah, I don't disagree with that at all, and I think that it just has to be sort of a patient-specific approach in a lot of ways. And now we have two, and we've done one each way. So, yeah.
Very interesting. Paul, your message here. What is your practice, clip and pre-op before an LVAD? And, well, I don't know if you have ever done a clip post. I mean, I don't.
Yeah, so I've done a clip. I've done an LVAD on someone who's already had a clip. That person had one clip, and I just left the clip in place, and it wasn't a problem. I have not done one where I was considering an LVAD, but whether to do a mitral clip beforehand and see how that responds. But I've always left. And the other thing I want to mention is the ventricle of people who have significant MR pre-op, who resolve their MR versus those who don't resolve their MR, are actually very different when you look at it biochemically. We've done some of these studies on LV cores, and it reveals that for people who don't resolve their MR, the ventricles are actually quite not viable. So there's not a lot of inflammation. It's a lot of fibrotic genes being expressed. So it may be that people who don't resolve their MR, or who have very large ventricles, are really the late stage heart failure, and their ventricles just don't contract, and you can offload their LV, but it just remains statically just dilated with very little contraction.
Sure. Thomas Salerno, please give us a words of wisdom from your island in Florida. I mean, you belong to that generation of heart surgeon who has an island per se. I mean, I joined this profession way too late. So tell me more.
Well, this is a great presentation. Obviously, the field is changing quite a bit. I'm not a heart failure surgeon, but I keep close observation with my colleagues in Miami. I think you know Matthias Loeb is here with his group and have a very active program. The field is changing quite a bit. I was just thinking aloud just before you mentioned the word clip. It seems to me that if you're going to do an alveoli repair during the procedure for someone who has mild or moderate MR, it's worthwhile. It's a simple thing. That's something I learned from Batista. When Batista was doing his Batista procedure, and that's how alveoli became famous, because he used to do this butterfly technique. And one day I asked him, what is this? Where did you learn this from? He says, oh, there's a guy in Milano doing this, alveoli. I said, well, you need to give credit to him. So if you're doing an alveoli repair when you take the core out, to me, this is a simpler procedure because LVAD is relatively simple. Obviously, the consequences are serious. But then a lot of our patients here who are presenting heart failure are undergoing a mitral clip. And very soon we're going to have or they're already doing tricuspid clips. So looking ahead, this is just something that the field is going to change, in which all these patients will have just an LVAD, see how they do. And if need be, put the clip later with the consequences as mentioned, that deploying a clip on someone that has an LVAD may have consequences. So it was a very interesting discussion. Obviously, each point that you made are extremely important. And I think this discussion will generate a lot of interest in heart failure surgeons. I certainly appreciate very much the discussion I just heard. I learned quite a bit. I don't practice heart failure, but it's quite an interesting discussion. The island here is in the middle of the Atlantic. It's a beautiful island. The temperature here is about 100 degrees. There's a swimming pool. Sometimes, I told you already, I go by plane, helicopter, boat. I just crossed the bridge. Welcome to the island. You're muted. You're muted, Gianluca. You're muted.
Gianluca, you're muted.
Oh, I'm muted. I said, don't tell to Leora that he's in line to do a 15 hours transplant. She's just waiting a phone call right now. The patient is like, don't tell how good is the temperature in your island. You will make her cry.
No, it sounds lovely. Maybe I'll go there after.
I wonder, Leora, if you could send me an email. Maybe you can become member of our editorial board. I don't know if you have the time of interest, but...
Oh, yeah, absolutely. Be happy to.
Send me an email, please.
So, Paul, give us a final word. So what is general message? You studied moderate MR. As Dr. Anyanwu have said, like generally, we don't recommend surgery for moderate. Would you redo the paper, first of all, like in studying it? And second is, what is your final message that, and in a very serious way, what type of message would you give to heart failure surgeons around the world for mitral valve surgery at the time of LVAD? What do you think are the 2 or 3 taking home message that you got after this conversation? I unmute you, so please, Paul.
Thank you. So thank you, Gianluca. I think it's a very interesting discussion. I think for my approach, I can't speak for anybody else, but for people with severe mitral regurgitation, you might want to consider repairing their mitral valve, placing a ring through a transeptal approach, or as Annie said, place a alveoli stitch through the apex. For people who have severe or significant right ventricular dysfunction, especially if they have severe tricuspid regurgitation, which suggests that right ventricular dysfunction is not solely due to volume overload. There's real geometrical remodeling there with the tricuspid regurgitation. And for people who have large left ventricles, where they're unlikely to resolve their MR. But noting that for a proportion of these patients, like Frank said, they may not need it. And I think The ultimate approach may be in the future through a transcatheter approach, where you identify people who have significant residual MR afterwards, and then place a mitral clip like Leora had done, or some other percutaneous approach that's evolving. There's a lot coming, the millipede and so on. And that would be my approach. And with regards to this paper, for moderate MR, I think the vast majority don't need it. I wouldn't do it.
Thank you. Thank you so much. Dr. Pagani, Dr. Anyanwu, one last words from you to give us whatever your feedback is. And in this subject, what do you think, Dr. Pagani, what do you think about mitral in LVAD and potential role of the future of mitral clip?
I think we still lack a lot of important information to make the critical decisions. I think I agree with that residual MR is bad, and I think repairing those patients that are at risk of residual MR is probably the correct approach. The problem is we can't identify those patients reliably, and I think that in the future it's likely that the transcatheter approaches might be utilized more because we can direct them at patients who we know are at risk or who have demonstrated that. So I think as comfort with the transcatheter techniques increase, we'll see that applied to the heart failure space, both pre and post LVAD.
Excellent. Ani, Dr. Anyanwu, please.
Yeah. So I think I actually adopted my approach from Walt Dembitsky, and I had these arguments with him over the years that I felt it was a waste of time repairing the mitral valve. But he convinced me over several discussions that our object in LVAD surgery should be to repair the native heart and then put an LVAD. So you want an LVAD placed on a heart that's functioning as normally as possible. And he gave me certain bases on which to believe that. And I think that strongly that where possible, you want to eliminate all the structural problems from the heart and then put an LVAD, and you'll likely get a better performance of the LVAD. And I think this is more important now because with the current allocation system, a short bridge to transplant, at least in New York where I practice, doesn't exist anymore. Most patients who have LVADs will have it for a few years, if not several years. So I think the functional state of the heart becomes more important. So our approach to all valve disease, tricuspid, aortic, pulmonary, is to fix it. Aortic would fix mild AI now, because I'm sure that their data from Michigan, actually very good data suggesting progression of mild MR, so mild AI. We'll close the appendage if there's any concern about that, prevent thromboembolism. Sometimes we even fix arrhythmias. But all these are problems that will come back to haunt you. And I think if you leave severe MR, those who are responders to LVAD, they're fine. But I think about a quarter wound. And as Dr. Pagani says, you don't know who those non-responders are. And you will end up with a patient crippled by heart failure, rehospitalizations, fluid retention, dyspnea, and so on, and just failure to thrive after an LVAD. So I think fix the native heart and put in an LVAD. That's our current approach.
Thank you so much. Leora, I let you for the last words. You told us you generally do not approach mitral valve during LVAD placement, even in severe. So does this discussion have changed your position? What you will do tomorrow morning on the patients that is in line for an LVAD and has severe mitral regurgitation or a bad right ventricle?
Yeah, absolutely. I am too young to be set in my ways, and I really do appreciate the expertise of this panel in techniques as well. I think that you're absolutely right. The landscape has changed for people with LVAD, and they're not going to go on to transplant, in short order. And so we do have to pay more attention to the residual heart. So I absolutely agree with you on that aspect, and having techniques that are straightforward, that are not going to add harm to the patient at the time of the LVAD placement. I think that's really important. And then, like I said before, really closely following patients for whom you may have missed or who may develop severe or have residual MR that's affecting them functionally. I think that's really important too. And then using some of our newer technologies to address that will be really important. So this field, as always, is in evolution.
Excellent. Thank you everyone for this contribution. I want to thanks from Journal of Cardiac Surgery, Dr. Tang and Dr. Pagani to submit their paper to Journal of Cardiac Surgery. As you know, every month we pick up one of the paper that catch our attention and we think has a very good topic. And we just sit over a weekend for an hour with a panelist of surgeons like you or cardiologists, and we try to have a discussion with different opinions to try to improve the outcomes of our patients and discuss these papers when they're still hot and they've just recently published. I just leave to Thomas Salerno the last goodbye for everyone, and thank you again. Thomas, is all yours, the panel and the floor, please.
Just again, thank you very much. Your contributions are very important to the journal and for our specialty in general. I wish you all the best and many thanks for your participation today. Thank you, Gianluca, and thank you, Irbaaz, for having organized the sessions.
Thank you.
Have a great day.
Thank you.